Welcome, everyone. It is noon, so we'll go ahead and get started. People will continue to join, and that is just fine. Thank you to everyone joining us on this cold and snowy day for this session of Keeping Kids Safe that's focused on self-harm. I'm Christy Ganya, and I'm a program manager for Telehealth ROCKS. Telehealth ROCKS is a federally funded program that works on school-based behavioral health, and we do this by working on social determinants, supporting school-based services, and telementoring trainings just like this one. We have just a few notes for you if we can go to the next slide. This session is being recorded and we will share it with you afterwards. Your microphones have been muted, but please feel free to chime in by either typing in the chat or unmuting to ask questions. And then it's very helpful if you can either type your name in the chat or make sure your first and last name are visible on your Zoom screen so that we can track attendance for this session. We don't have any disclosures, no financial disclosures, and we are, everything is evidence-based and currently accepted within the profession that we're talking about today. Next slide, please. And then just a few reminders for after the session, we will send you all of the resources via email. So the slides, the recording, any resource links that are put in the chat, we will send those to you afterwards via email. Just give us a little bit of time because we've got to process the recording. And then the certificates of attendance for the sessions this winter and spring will be sent after the last session in March. So they'll all be calculated and sent out then. And then if there are any questions that we don't get answered during the session or come to you later, feel free to email us at any time and we are happy to help answer those for you. So with that, I will hand it to Meg to let us get started here today. Thanks for being here.
Hi, everyone. My name's Meg Hasselman. I use she, her pronouns. I have a license, I'm a master level social worker, and I work for the Suicide Prevention Center here in Kansas, which I'll talk a little bit more about going forward. But this is sort of an overview of what we're going to be talking about today. We're going to review some important terms that can help make sure that we're really all on the same page when it comes to vocab surrounding suicide and self-harm. We're going to really dive in pretty deep to the why behind self-harm. We're going to discuss some specific strategies for supporting youth through self-harming incidences. We'll learn about some available treatment options, and then we will also talk about creating a collaborative safety plan. I will not be reading the chat as we go, so Christy, feel free to interrupt if there are any questions that are pertinent to the information we're currently discussing. I did want to mention that we are discussing a sensitive topic today. So if you find that you're not in a place emotionally or mentally to sit through very graphic depictions of self-harm and conversations around self-harm, please feel free to log off. I would be happy to have a conversation with you outside of this in a way that feels safer for you. So please reach out if that's something that you wish. Otherwise, just make sure that you do what you need to care for yourselves. Contact a supported trust person, or you can call 988 for support if you find that you need some external support. So HeadQuarters Kansas is the main 988 operator for the state of Kansas. So we answer calls, text, and chat that come into the lifeline. We do provide that for free, and it's confidential, and it's available 24/7. And then we also navigate mobile response by referral for our local emergency department or emergency response. We do provide training and education for communities, behavioral healthcare systems, educational systems, and we also provide volunteer training for folks who answer the National Suicide Prevention Lifeline. And then we do some public awareness campaigns as well and advocacy up at the State House to support legislation that will improve care for suicide. So let's go ahead and get started. So these are some important terms that oftentimes people don't have a super in-depth understanding of, and in turn can cause some confusion when youth specifically go in for suicide screenings or assessments or screening for self-harm. So I think it's really important that we all really understand these terms in the same way And when you're working within a system, whether it's a school system or a behavioral healthcare system, it's really important that the entire system operates with the same understanding of these definitions as well. So if you are someone who works pretty frequently with youth, it's a good idea to have a conversation about what these terms mean. So non-suicidal self-injury, or NSSI, is the same thing as self-harm. Researchers really use that non-suicidal self-injury term. I will likely refer to it as self-harm throughout this presentation, honestly, just because non-suicidal self-injury is a mouthful. So I will refer to it as self-harm. So we know that self-harm is defined as any self-injurious behavior that a person engages in without the intention to die. So this is purely 100% for reasons other than wanting to die. And another way to put this is that no part of the person wanted to die as a result of their self-injurious actions. We'll talk a lot more about self-harm going through this presentation, but we'll keep it simple for now. We know that self-harm is used as a coping mechanism, right? We may not view it as the healthiest coping mechanism, and certainly not the one that we want people to choose, but it is a way of coping nonetheless. And we know that people choose to engage in self-harm or NSSI for many different reasons, and we will dive into that much deeper going forward, but we're going to move on for now to suicide attempt. So a suicide attempt is also a self-injurious act, but this is committed with at least some intent to die as a result of that act. So a suicide attempt does not have to result in injury or harm. It just has to be that intent and behavior are linked. So what is the intent behind the action? If the intent is to die, that's a suicide attempt, even if the person wasn't injured. So an interrupted suicide attempt is when someone starts to take steps to end their life, but someone or something stops them. So that's an external force that is stopping them. So the example that I will share is maybe someone has a bottle of pills in their hand or a firearm in their hand, and somebody walks in and takes the method from them. That is an interrupted attempt. An aborted suicide attempt is when someone starts to take steps to end their life, but they stop themselves. So maybe someone is driving their car, they have intention to crash their car to end their life, but they decide they're not going to do that. So they pull the car over and call someone instead, or they turn around and just go home instead. So that would be an aborted attempt. And then preparatory behavior is any action taken with the intention to die later. And this is beyond just saying something about suicide. So this might look like somebody stockpiling pills or acquiring a firearm or writing a suicide note. It could look like sorting out care for pets or loved ones or other responsibilities, right? So any action or behavior that somebody is engaging in to prepare for a suicide attempt. And we know that preparatory behaviors are highly indicative of a future attempt. And so if we know that someone is engaging in these behaviors, we really want to be on top of that. But this presentation is not focusing on suicide prevention. We're talking about self-harm, so I won't dive in too deep to that. To be quite frank, that's a challenge for me because I live in the world of suicide prevention. So steering away from that too much it can be a challenge for me. Okay. So it's really important to be aware of some risk factors for self-harming behaviors. It doesn't mean that somebody who experiences these things is inevitably going to self-harm. It just means that risk of self-harming increases. So we know that really any history of trauma, so if we think about ACEs or adverse childhood experiences, those are risk factors that indicate there could be a chance of self-harm behavior associated with that. A history of emotion dysregulation or sensitivity, tendency towards negative cognitive style rumination, presence of other mental health conditions, most notably depression, anxiety, and disordered eating or eating disorders, low affective family environments, and feelings of shame. Feelings of shame was specifically noted and highlighted as a risk factor for self-harm because it is a common experience in young people. So if we think about things like fat shaming or body shaming or shaming for any other reason, those feelings of shame inevitably do increase risk for a lot of problem behaviors, but self-harm specifically, since that's the focus of this presentation. It is rather difficult to gather really clear specific data on self-harm because there is typically a lot of nuance in that data. So I just wanted to highlight a few things that really stuck out to me as being things to be aware of. So we know that rates of high school students that report self-harming ranges from 6.4% to 14.8% for males and 17.7% for females, and that's from 2015. I want to really highlight that this is very binary, so it's not including our trans individuals or our non-binary folks, but we do know that prevalence of self-harm, suicidal thoughts and behaviors is particularly high in the LGBTQ+ community. It is not the identity itself that increases that risk. It is the social consequences of holding those identities that increase risk for not only self-harm, but suicide as well. The average age of first incident of self-harm is around the age of 13. Typically, when someone starts to engage in self-harming behaviors, it can be a multiple year process of getting someone help. But a lot of times youth will engage in self-harm as a one-time thing and never return to it as well. Youth that visit self-harm or suicide websites are 11 times more likely to have thoughts about hurting themselves. So it's really important that if you are a parent of a young person who is online, that you're sort of paying attention to the websites that they're visiting and having a deeper understanding of what some of the contributing factors might look like. And then there's a really high comorbidity of folks with eating disorders and folks who self-harm. So we know that folks who have eating disorders are at one of the most heightened risks of suicide because, let me rephrase that. People who have eating disorders are at a heightened risk of suicide because of that comorbidity. Okay, so these are different types of an SSI or self-harm. So episodic self-harming is someone who engages in self-harm behaviors every so often. These folks typically don't identify as someone who self-injures. So if you were to ask them, do you self-harm, they're likely to say no right out of the gate because it's typically something that they engage in during a moment of heightened emotions. And we'll talk a little bit more about that going forward too. Repetitive in SSI is someone who engages in self-harm on a regular basis, and they typically do identify as someone who self-injures. So if you were to ask them, do you engage in self-harm, they're more likely to say yes than someone who engages in self-harm in this episodic nature. Compulsive self-harm is ritualistic. So this is someone who has a very specific way of self-harming. It's performed in a sort of ritualistic way. It oftentimes is not premeditated, and they will still engage in that ritualistic aspect of self-harming. Stereotypic in SSI or self-harm is associated with other disabilities. So if I think about someone who has autism spectrum disorder, right, and maybe they do some head banging or repetitive punching of the face, something like that. Major self-harm or non-suicidal self-injury is typically related to psychosis. This is relatively rare. In incidences of major non-suicidal self-injury, the injuries typically are very drastic. So it might look like somebody who attempts to amputate a body part or something of that nature. So like I said, very severe behaviors associated with major NSSI. And then indirect NSSI are these sort of self-destructive behaviors that are harmful, but there's no specific intent to harm oneself. So it's not that someone is engaging in these behaviors as a way to self-harm, but the behaviors themselves are harmful to one's body. So that might look like, if I think about somebody who is using a really high potency drug, or somebody who is drinking major quantities of alcohol or something like that. It could also look like somebody who is drinking and driving, or doing something that's really risky, and maybe there's not like that, like I said, that intent to harm themselves, but it is by nature just a harmful behavior. And then there's also this experimenter or follower group that's not on this page, but it's a group of people who tend to begin as part of like a common or like episodic group. And it can become more common over time for that person to engage in that behavior. So this might be the people who are doing it because their friends are doing it, right? So these are the most common methods for NSSI, or most noted, I guess. So cutting, burning, impact with an object, ripping or tearing of the skin, hair pulling, scratching or pinching, carving in the skin, rubbing with an object, so like an eraser or something like that. Impact with the self, so banging your head or your body against a wall, or interfering with healing. So making it so that the wound is not able to heal because you're picking at the wound or re-engaging that wound. I would say that there probably are others that you all have seen if you work with youth that maybe aren't on this list. But these are what are most commonly known as being behaviors associated with that self-harm. Okay, so now we're really going to dive into the why behind self-harm, which I think tends to be a really big question that we as adults have when we're working with youth. So I want you to think about a behavior that you engage with that maybe isn't like your best coping skill. So for me, I think one of my biggest behaviors that I engage in when I'm not utilizing my coping skills is avoidance. And avoidance is a very harmful behavior, right? Because it puts me behind in work. It oftentimes puts me behind in things at home. It isn't my favorite choice for coping with something, but it is something that naturally occurs. You could think about somebody who could polish off a box of chocolates, right? That could also be something that's considered that indirect self-harming behavior. I think sometimes if you break it down to that really simple answer, it can help you have a better understanding of why people engage in self-harm, because you know, there are probably coping skills that we try more heavily to rely on, and sometimes we fall onto those more negative type coping skills. So maybe just something to kind of think about there. But the information we're going to cover here is based off of an assessment of self-harm. It is information that it was derived from a non-suicidal self-injury assessment tool. So this is information that is directly from folks who engage in self-harm, specifically youth. And the information that they share really are in 5 different categories. So one reason that people might engage in self-harm is to regulate negative affect or no affect at all. So coping with uncomfortable feelings, to deal with anger, to feel something. So maybe someone's experiencing numbness, they're not able to feel something, and engaging in self-harm allows them to feel something. It can help to relieve stress or pressure, or that overwhelming sense of like there's too much going on. Sometimes people engage in self-harm to deal with frustrations that they're experiencing in their life, or to elicit an emotional response like crying. So if somebody is like, oh, I really want to cry, but I'm not able to cry right now, engaging in self-harm may be able to help release that. And we'll talk about a little bit of the science behind why this all works too, but we're going to cover these things first. There's also this element of social communication or belonging. So sometimes people engage in these behaviors in the hopes that someone will notice these wounds on their body. Sometimes it's used as a way to shock or hurt someone. And I mentioned earlier that sometimes people do it because their friends did it. I think that's something pretty common that we hear with kids. I want to point out that for the social communication and belonging piece, self-harm can be used as a form of manipulation, right? And I'm not saying that from a place of judgment, just that it is exactly that. It is a type of way to connect with people or make people feel a certain way about the things that you're doing. So just at its simplest form, it is a type of manipulation. Whether or not someone is intending to be manipulative, it is still manipulation. A lot of times self-punishment and deterrence are also contributing factors. So atoning for one's sins, it can be a way to express hatred that someone has for themselves. Sometimes people engage in self-harm to avoid hurting themselves in other ways. So it may be actually the safer way for someone to cope, right? Because if someone is trying to avoid killing themselves by engaging in self-harm, right, it is a less harmful behavior. And then to avoid tempting suicide. Oh, sorry, I think I didn't have it on the right slide. My apologies there. And then we also have sensation seeking. So if somebody just has this uncontrollable urge, or if someone just thinks it feels good, there's also this idea that you get this rush or surge of energy after self-harming. And sometimes people state that they just like the way it looks. I would also say that if someone does it because they like the way it looks, it could also fall into this social communication or belonging piece to elicit a response from somebody. Self-destruction, so it could be a distraction from other problems or tasks. It could create an outlet as a way to avoid having to do something else. So these are sort of the most common reasons behind why youth engage in self-harm, but that doesn't necessarily answer the question of like, why does someone put their body through that? And so I think when we talk about pain offset relief phenomenon, we really start to get at some of the answers that we're really looking for. Before I dive in here, I just wanted to check in and see if there are any questions so far. I guess this would be a good time for me to check the chat. Just introductions. Okay, no questions. All right. So most people have this idea that self-harming helps people to deal with really strong or negative emotions, but like I said, lack an understanding of how it works or why self-harming is effective. So there was a study done in 2010 in the Journal of Abnormal Psychology, where researchers were seeking more information on why people engage in self-harm. I'm going to put this really simply because I'm not a scientist, and trying to explain it like a scientist will inevitably make us all feel really confused. So I'll keep it simple. What they did in this study is they measured people's eye blink responses when their body was in defense. And they did this before and after they had the participants in the study dip their hands into ice cold water. I don't know about you all, but when I was in high school, I was an athlete and I had to take ice baths, and I found them to be incredibly painful, right? So when you dip your hand into ice cold water, there is actually a sensation of pain associated with that. What they saw based on the way people's eyes responded to the cold water, it was able to indicate that people who engage in self-injuring their bodies on purpose typically will have a sense of relief afterwards. So pain offset relief phenomenon says or explains essentially that everyone experiences unpleasant physical reactions to a painful stimulus, right? Like putting your hand in ice water. But when you remove the stimulus, taking your hand out of the ice water, the individual typically won't return to their pre-pain state, right? So they typically won't, if someone was really upset before they dipped their hand in ice cold water, and then they remove their hand, they're typically not going to return to the same state that they were in before the ice cold water, right? And that's because the removal of the painful stimulus leads the person into this really short but intense state of euphoria. Over a long period of time, people start to associate pain with relief because of this pain offset relief phenomenon. There is a whole lot of information about this phenomenon out there that I think can answer some of those questions behind self-harming, but I just wanted to give a quick overview of that because I think it helps us to have a better understanding. But if you're really someone who loves science and wants to dive into the like chemical reactions and all of that, you can definitely find some information online. Okay, so we've really level set and we're all on the same page now about different terms, about risk factors for self-harm, about the reasons behind self-harming behaviors. So now we're going to move into what can we do going forward? So we can respond. So what that looks like is acknowledging the crisis or the pain. We are going to assess. We're going to find out more about the intent and safety behind or of the individual who's self-harming. And the following slides dive into all of this much deeper. We're going to engage with the person who's self-harming. So we're going to show a lot of empathy and we're going to provide a lot of support. We're going to spend some time educating, and that might look like educating the person who's self-harming, their family or their support system. We're going to talk about the risk and reality of them staying safe, and then we're going to make some referrals, right, to community resources or people who can help long-term. So based off of what I saw in the chat, most of you work at schools, right? And that could be that you're maybe spend just like 20 seconds typing what your role is at your school that you work at. What are your roles at your school or at your job in general? Okay, school-based therapist, social worker, mental health liaison, school district social worker. Oh, hi, Janice. Special education, preventionist. Hi, Lydia, school counselor. Okay, so a lot of you are folks who work directly with at-risk youth. It's not that you're teachers. So you all might be someone who is providing ongoing support or longer-term support, maybe not in a clinical setting, but in a support kind of role. All right. So diving in a little bit more about to that first component, which is we're going to respond to someone who is engaging in self-harm. We really want to do that non-judgmentally, and we want to immediately identify it and respond to it. And we're also going to be really direct about that. I know it may seem intuitive to not be judgmental about it, but a lot of times we have responses because responses that's come off as judgmental because we are coming from a place of concern or worry. And so pay close attention to the way that you're responding. If you have an immediate reaction that is not favorable or that is not supportive, that's okay. This is a really tough thing to walk someone through, but really try to navigate that on your own and don't put it onto the person who is engaging in self-harm, because we don't want to increase feelings of shame, right? We really want to do our best to start reducing some of those feelings of shame and allowing people to feel like they can talk about what's going on that's leading them to engaging in this behavior. So really avoid shock or emotional displays as a reaction. I had my colleague and I were doing some post-vention response. So there was a suicide death in a community and we were there providing support for the students, and one student showed my colleague this really intense wound. And afterwards, my colleague was like really upset about it, right? But in the moment, she was able to ground herself and not show this big reaction because she didn't want to scare the youth that had engaged in this behavior. And she certainly didn't want to shut them down, right? Because she'd gotten them talking, got them to a point where they were willing to show her the wound, not because she invited that, but because they felt that they could trust her. So spend a lot of time validating and encouraging that person. So it sounds like you've been going through a lot, can be something really helpful to say. It takes a lot of courage to talk to me about this. Thank you for trusting me. Those kind of things go a long way. We're not going to insist on seeing the wound. If somebody comes forth and expresses that they have been self-harming, it isn't really our job to say, show me that wound, right? But we can ask some questions. How bad is this wound? Is it still bleeding? Were you able to get the bleeding to stop, right? Trying to kind of gather some information about the wound without forcing the youth to show us the wound. Now, if we are a medical professional or we're taking the youth to the school nurse or something like that, I think that's a different story. But for now, we want to make sure. I got distracted by the chat and I told myself I wasn't going to do this, but it seems like we have a question. Can you share how to respond to the student who is in distress by their own behavior, a student asking questions in the vein of, am I crazy? Yeah, so if you have a student who is like actively upset by their own self-harming behavior and they're like, this must mean I'm crazy, I think it's absolutely important that we say, you are not crazy, right? This is a way of trying to cope with the pain that you've been experiencing. Do I want a coping mechanism for you that doesn't involve harming your body? Absolutely. But what this self-harming behavior is telling me is that you are looking for a way to cope. And I think we can talk about some ways that you can cope without inflicting harm onto your body. Something like that, right? Does that help, Evelyn, or is that a helpful answer?
That is super helpful. I've had that come up, and it's really helpful to hear how you say that and redirect to like, yeah, we want to find other ways too, but you're not crazy. Thank you.
Yeah, absolutely. Thanks for the question. We don't want to minimize the youth's experience. So we definitely don't want to say something like, you did this over a breakup. Are you kidding me? Right? You want to really avoid responding in those ways. Whatever the youth is experiencing is valid. And we have to remember that brain development. So their brains aren't fully developed. That prefrontal cortex is not fully developed. And so their ability to regulate their emotions, to use logic in thinking about the ways to cope, right? That's not as developed as ours is as an adult. And so we have to have some grace and compassion for them because they're trying to cope in a way that makes sense to them. Sometimes asking the question, why did you do that? It can seem like we're trying to gather the right information, but a lot of times if we pose it in that way, youth are less likely to just be honest about why they did it. And they may be more likely to say something like, I don't know why I did it, or I did it because my friend did it, even if that's not true, right? So it can be helpful to ask questions like, how long have you been hurting yourself? Where on your body do you typically hurt yourself? What do you do to take care of the wound afterwards? Like just some harm reduction, right? Making sure that they're using an antibacterial soap or something like that can be really important. You can also ask, is this instance of self-harm more severe than past instances of self-harm? So trying to gather, is this wound more serious than others that you've experienced? And then we're going to assess. This does not have to be done in a formal way, although if you do have an assessment tool, that's also perfectly appropriate to use. But what we're really looking for in this assess piece is the youth in immediate danger? So some of those questions like, is this wound pretty typical or is it worse than normal, can help you understand the immediate danger or severity of the wound. It is always important to ask about suicide in instances of self-harm, but what I want you to hear me say is that suicide and self-harm are different, right? We've kind of talked about it in the past slides about the intent behind the behavior, but we always want to ask if somebody is thinking about suicide, just because we know that self-harm does increase risk for suicide, but it typically doesn't mean that somebody is thinking about suicide. And I know that's confusing. So if you have more questions about that, please let me know. You want to assess the risk of contagion. So do other students know that you've been self-harming? Do you know if any of your friends have been self-harming? Things like that. And then it's also helpful to try to gain an understanding of the prevalence of self-harm in the overall student population, which can be really hard to do and it's not super straightforward. But if you're noticing a pattern, it can be super helpful to start talking to those kids. When we get to the discussion slide, I have a pretty good example of how I've seen a social worker in a school really start to identify this prevalence, and I will talk about it, but you might have to remind me. So when we get to the discussion slide, if I don't bring it up, just remind me. The next thing we're going to do is engage with the youth. We're going to engage with the family or the support that typically is surrounding that youth. It's helpful to know if the student's friends are aware of the self-harming, and if they do, let's pull them in and talk to them about ways to take care of themselves, right? And see if there's an underlying cause for this self-harming behavior. Really important to connect with subject matter experts in your community. So that might look like engaging a therapist at a community mental health center or a crisis center.
And Meg, I think we might need to advance the slide just one.
Oh, I'm sorry.
That's right. We're seeing the assess slide right now.
Thank you.
No problem.
I have two up so that I can see my notes, so I apologize. We want to make sure that we are engaging family supports, right? Because a lot of times a youth really needs that additional support, and it's important that the people that they live with be on the same page. And we know that that's not always an option, but if it is an option that can be utilized, it's really important that we do that. And then create a plan for safety, and we're going to talk about that now. So this is the Stanley and Brown safety plan. This safety plan was developed for suicide risk, but it can be used for so many different things. So when I was a practicing therapist, I used this safety plan for people who were experiencing grief, who were trying to recover from an eating disorder, who were thinking about suicide, right? So you can use it for a lot of different reasons. The first thing on the safety plan is what are some warning signs that arise that indicate that a crisis may be developing or that a crisis is already happening. When you're walking through this with youth, you might have to provide some examples. So warning signs, and we want to do that from the context of our own selves. So we're not going to try to assign warning signs to the youth, right? We can provide examples from our own context and see what that brings up for them. So it might sound like, you know, when I'm experiencing a crisis, I tend to avoid phone calls. I sleep a lot more. I get really anxious in my stomach, and I have ruminating thoughts. Do you ever experience things like that or similar things? We want to put this specifically on the warning or on the safety plan so that you can glimpse it, right? And see, oh, I have been engaging in this avoidance behavior, which is one of my warning signs, right? So it can really help the person who is using the safety plan identify if they are in a place of struggling. And then we're going to talk about internal coping strategies. So these are things that the person can engage in by themselves, and it can typically look like a hobby, right? So this for me would look like doing some yoga, crocheting, watching some Netflix, maybe going on a walk or getting some fresh air. The third is distraction. So people or places that provide distraction. These are not going to be people that you call and say, hey, I'm really struggling right now. I need some support. But you might call them and say, hey, how are you doing? What's going on in your life? This could be a great time to call your friend who's really funny and makes you laugh a lot, but maybe isn't the best listener, right? Or maybe there are some places that you enjoy going that can provide distraction, like a coffee shop or the library or a Target, something like that. People that you can ask for help. So these would be the people that you do call and say, hey, I'm struggling and need some support. It can be helpful to inform the person that you're putting on the safety plan that you're adding them to this so that they know if you call them and say, I'm struggling, they have some ideas of ways that they can help you. When we're working with youth, it is absolutely okay for them to put some of their friends on this step for number 4. But we also want to make sure that there's at least one adult who they can engage with if they do need some help. Step 5 are professionals you can ask for help. I always include 988 or other crisis resources depending on what the person is experiencing. So this is where you might put primary care doctors or therapists or case managers. And then making the environment safe. So, what are the methods that you typically self-harm with? Are there ways that we can put those out of sight, out of mind, lock them up, remove them from the home? Maybe you need to stay somewhere else, that kind of thing. But we're also really looking at ways to calm somebody's nervous system down. So I like to think about engaging the 5 senses. So are there certain smells that are particularly calming, textures of clothing, things that people can eat, temperature of the room, lighting, those kinds of things. It is important when working on a safety plan that we don't put pressure on someone to have an answer for every single step. That would be ideal. And we also know that that isn't always available to people. So as long as there are other parts of the safety plan filled out, that's okay. That's a good safety plan. If someone agrees to utilize the safety plan, that's how we know it's a good one. I have seen youth make safety plans in a lot of really creative ways too. So we want to make sure that the person who's at risk is the one who's really offering up all of the ideas for the safety plan. It would be best if they were the ones writing it down. It's not always possible for that to be the case, and that's okay. I've had youth who've made collages or like personal molecules where they have like branches off of themselves. They can get really creative. It doesn't just have to be a list. So this can also just be a nice prevention activity for folks if they're looking for things to do with their students or their youth. Okay, so continuing on what can we do to support youth who are engaging in self-harm? So for this education piece, making sure that staff are going through gatekeeper trainings for staff who specifically work with youth. Great idea, right? To make sure that they're getting some trainings for these, what am I trying to say? I guess problem behaviors, right? We can also ensure that staff are aware of local resources. That is really important, not just for mental health staff at schools to be aware of, but for all school staff to be aware of, right? So teachers, lunchroom folks, janitorial staff, administration, all of these folks are really engaging with youth on a regular basis and should be aware of the resources that are available in the community. And then finding ways to highlight and encourage healthy coping skills can be really effective in replacing some of those negative coping skills or that self-harming behavior. The next thing we're going to do is make a referral. So we want to make sure that the self-injuring youth gets connected to ongoing professional support immediately. And that might be you as the school mental health professional, but it also might be someone making a referral to a community mental health center or a crisis center or something like that. So these are different evidence-based interventions that have shown effectiveness in treating youth with self-harming behaviors. I want to make it really clear that these are not always the most accessible for some youth, right? So on the next slide, we're going to talk about the common themes that all of these interventions include that make their programming so effective, so that there can be some modeling of these different interventions. There is a resource that will be shared in the chat that has, I have my copy right here. Let me show you. It's treatment for suicidal ideation, self-harm, and suicide attempts among youth. This is a whole study on different interventions that are effective. And so this will dive in a lot deeper to all of these different treatment modalities that will be shared with you at the end of the presentation. So I'm not going to spend a whole lot of time diving into these right now. But the things that all of those programs or interventions have in common are these 5 elements. So comprehensive assessment. So prior to initiating treatment or during the first sessions of treatment, a clinical assessment that includes the history of the student's thoughts, behaviors, mood, previous self-harm or suicide attempts, trauma history, health history, home life, right? All of those things are assessed so that the person working with the youth can get a full clinical picture of what is contributing to this risk, to this youth's risk. And then safety planning, which we kind of already talked through those 6 different elements of safety planning. But this is an evidence-based treatment approach. So we know that individuals who receive safety planning are actually less likely to experience suicidal behavior, self-harm. They're less likely to be hospitalized, and they're more than twice as likely to to have engagement in mental health services. So safety planning is really one of the most effective things that we can do when working with youth at risk of self-harm or suicide. Family involvement is a really important component. So that's involving parents, caregivers, or other supportive adults in the youth's treatment program. So that can help to strengthen the support system as well. And it also increases the youth's help-seeking behaviors and can create more positive relationships with those adults in their life. Coping skills training. We know that when youth are learning about coping skills, if they have the ability to practice applying these coping skills in a safe environment, it can be more likely that they'll engage in those behaviors outside of that safe environment. I think that there are a lot of ways that coping skills training can look. It's not just going to therapy. So it could be that the whole family is engaging in creating a list of activities to engage in when stress is really high, right? That's just a small example, but there are tons of ways that you can start having conversations about coping skills, and it doesn't have to be that you're doing it in a therapeutic environment. And then continuity of care. We know that if somebody has consistent access to care, their adverse outcomes are much less likely to occur. But again, it can be hard for some folks to access that continuity of care. So that might look like engaging in school supports more robustly, or it might look like having a plan for checking in with the student, once a week or something like that. So these are some resources that I have found to be really helpful in this work with self-harm. So this Self-Injury in Youth by Mental Health of America is a nice website that really kind of spells out ways that you can support youth and some different opportunities for engaging in healthier behaviors. There is a podcast that I discovered recently called The Psychology of Self-Injury. It is a really good podcast that has 2 seasons of just tons and tons of information around self-harm and how to support youth who engage in self-harm. And it also, highlights some lived experience stories. So it has some episodes of youth who engage in self-harm with their parents, and they're kind of talking about what the road to recovery looked like. Or they have a lot of experts on that talk about different elements of self-harm. So anyway, can't speak highly enough of that. It really was a resource I was super excited about. Safe Alternatives is a great website that helps families and youth really paint a picture of some different opportunities for engaging in healthier behaviors. The toolkit that I mentioned earlier is by SAMHSA, which is the Substance Abuse and Mental Health Services Administration. This study that's linked here, let me see here. Okay, perfect. Yeah, Christy put the link in the chat. Really good research document to kind of help paint a picture of different resources that are effective. And then 988 is just a wonderful resource for youth. They can receive calls, texts, and chats. It's available 24/7. Your call or outreach to 988 does not have to be related to suicide. It can be about self-harm. It can be about just having a bad day. It can be about a trauma experience, like you name it, you can call 988 for that reason. And then because of the nature of this presentation, it's a really heavy topic, right? And a lot of times self-harm surrounds somebody trying to make themselves feel more grounded. And so I wanted to hear from you all something that makes you feel more grounded or connected to life. And we're going to There's a link in the chat that Chrissy has put in there. So you can click on the link and fill out the poll, and she'll pull it up here and put it on the screen for us.
Yep, and just a note, you can skip where it asks filling out your name and go ahead and type in a word. And then you can also, if it's 2 words, just link them with a hyphen or type them all together so that they show up together on the list.
Perfect, thank you. Friendship, breathing, family, outdoors, walk in the park, prayer, journaling. I love watching word clouds be built. Someone in the chat said fresh air. I agree. There was a study I read recently, just while we're kind of watching this unfold, where spending just 3 days a week outside for 20 minutes can significantly improve rates of depression. Or spending 5 hours total a month outside. It doesn't matter how that's split up. It can also really improve your outlook. Even if you're not an outdoorsy person, the outdoors are still very healing for folks. Reading, nature, feeling wind in the breeze. That's a big one for me too. Awesome. Thank you so much for sharing these things that make you feel grounded. I think it's always really important when we're talking about heavy and hard topics to also acknowledge some of the lightness and the positive experiences that we have as well. So feel free to keep adding to it. I'm going to pull us back to the presentation. Am I on the right slide? Okay. All right, so that concludes the information that I have for you all. And I do have an example to share, but I wanted to first pause and see if anybody else has anything that they'd like to discuss as it relates to self-harm, or any questions that may have arisen.
And I don't see any in the chat right now, but feel free to either type in the chat or unmute and say it out loud. And then we did just have one that popped in. Do you want me to read that to you, or is it? Okay. This one says, I have heard providers who agree and others who disagree. I would like to hear your thoughts, the appropriateness of a harm reduction type of coping skill for self-harm, like using a red marker versus cutting.
So that's a really good question. I want to make it clear that I'm not a medical provider or a clinician at this point, but I believe that harm reduction techniques are really effective in helping youth start to work towards more positive or pro-social coping skills. So yeah, like using the red marker or rubber band or like ice water or ice cubes can be really helpful with the urge to self-harm without having you know, personal injury to the body or things like that. That's a great question. Any other questions? While we're waiting for questions to come in, I'll share the example that I have for a school social worker who, I guess I'll start from the beginning. So it was the same instance where we were providing post-vention support in a community that had lost a number of students to suicide. And we were at this school and we were providing crisis counseling. And while I was there, the school social worker came in and told me that a student had been identified as engaging in self-harming behavior. And he had pulled that student out of class and brought them to his office and had a conversation with the student. And then sent the student to talk to me. And while I was talking with the student who was accused of self-harm, the teacher or the school social worker also called up individually all of the other youth that had been named as people that were involved in a conversation around self-harm. And then the school social worker contacted the families of these youth and were able to really get them to a point of being willing to accept help outside of the school. And you know, he did sort of an investigation and was able to find that really none of the students were engaging in self-harm. It was a conversation that they had. The reason I like this example is because the social worker heard about this, took it seriously, and followed up with all of the students and then involved their families. And when he talked to their families, he did a lot of education around why self-harm can be a coping skill that youth rely on. And he also did a lot of educating on ways to get those youth connected to help. And so the school social worker, had a lot of feelings about spending a majority of his day kind of navigating that whole situation. But what really the outcome of it was that, all of these youth were feeling more connected to an adult, were able to talk to their families about it, right? And that really helps with that prevention piece. So there's a question in the chat. What would be a good way to respond to a student that keeps cutting because she doesn't like to see the cuts healing or scars fading? So that's tricky, right? That's kind of that piece I was talking about where students, one form of self-harm is to stop the healing process of past behaviors. So I think that just calling it as you see it can be really helpful. Instead of trying to focus on, why are you re-engaging with this behavior? Let's talk about why you're engaging in this behavior in the first place. And then maybe we can also talk about some strategies for, connecting you with long-term support, or potentially getting you connected to some other ways to cope with that, the emotions underneath the self-harming behavior. I don't think it's a one-size-fits-all. But I think really trying to get to the root cause is effective rather than focusing on the self-harm itself, which is probably a strategy you've tried. And I think persistence in self-harm incidences is really helpful. If you have more questions, we don't have a lot of time, so that's why I'm rushing the answer. Please feel free to reach out to me. I'll put my email here in the chat. Okay. So if you took nothing away from the presentation, these three would be the key takeaways that I would hope you would walk away with. That self-harm is self-inflicted injury with no intent to die as a result of that injury. So really separating the fear of a student being suicidal if they're engaging in self-harm. Again, we really want to be checking in specifically about suicide, but I think it's important to know that the intent behind those behaviors are different. It's really important not to dismiss or diminish a youth's experience surrounding self-injury, and there are effective interventions to treat youth who engage in self-harm. And we know that even if someone just engages in creating a safety plan, it can increase chances of safety. So a whole treatment process may not be necessary. Last minute or two for questions or anything that anyone would like to share. All right.
Thank you, Meg, for sharing today. We so appreciate you leading this session and discussing this difficult topic with thoughtfulness and with compassion. Thank you to everyone who joined us today. We will send the slides and the follow-up materials to your email. They'll also be available on the Telehealth ROCKS website and Facebook page, and I'm putting those links here in the chat. We hope to see you at the next session on February 7th at noon for a discussion on disordered eating. And thank you everyone so much. Take care and have a good afternoon.